Hello, I'm Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled, and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to the PowerPoint presentation will be posted in the chat, so you can access the links on this slide. To receive continuing education credit, you must complete the session evaluation, including an attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of this webinar. We will also send you an email with a link to the evaluation following the webinar. The continuing education survey link will let you complete the evaluation for one or both webinar sessions if you plan to attend tomorrow's webinar too. If you need to edit your response after submission, you can also click the same link. We will only be providing continuing education credit for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Please note that the focus of this webinar is on clinical work with the older adult population. We are not addressing enrollment and other administrative issues today, but you can find information on the coalition members' websites and in future webinars on these topics. Next. This is the 8th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information for videos of the previous presentations on the next 2 slides. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Today, we kick off back-to-back webinars in collaboration with the E4 Center of Excellence for Behavioral Health Disparities in Aging. Today and tomorrow, we will be joined by 2 phenomenal and highly qualified professionals who will share information and strategies to help you address the clinical needs of older adults with mental health conditions. Today's webinar is titled Adult Mental Health 101, and tomorrow's will be the process of working with older adults in psychotherapy. The speakers will answer your questions at the end of the presentation. I would now like to introduce our speakers. Their full bios are in the slides for your convenience. Erin Emery Tabricio is a professor of psychiatry, behavioral sciences, and geriatric medicine, and the director of the geropsychology at Rush University Medical Center. She is also co-director of the Rush Center for Excellence in Aging, co-director of Catch On, the HRSA-funded geriatric workforce enhancement program based at Rush University Medical Center, and co-director of the E4 of Excellence for Behavioral Health Disparities in Aging. Next. Matthew Fullen is an associate professor at Virginia Tech, where he teaches in the counselor education program. His research, teaching, and advocacy focus on the mental health needs of older adults with an emphasis on addressing gaps in Medicare mental health policy and developing programs to enhance resilience and wellness and prevent suicide among older adults. Dr. Fullen is the counseling profession's most active scholar on aging and mental health, with over 40 peer-reviewed publications and over 95 peer-reviewed conference presentations and keynotes. Welcome to you both. I would now like to invite you to begin your presentation.
Thank you so much, Jolie, and grateful to all of you who have come to join us today. We have a lot of content packed into just an hour, and so we're going to fly through some of this with the intent that this will whet your appetite to learn more and come and learn some more with us at the E4 Center. So just a quick comment about the E4 Center. Get my slides going here. The E4 Center is designed to engage, empower, and educate healthcare providers and community-based organizations for equity in behavioral health for older adults and their families across the U.S. We're largely focused on depression, suicide, substance use disorders, and serious mental illness, and where these overlap to either create or exacerbate physical health issues among older adults, and certainly where these are layered on top of individuals who are experiencing low socioeconomic status and or are of ethnic or racial minority status. So with E4, we are we are engaged in a wide variety of different kinds of activities. We have training on evidence-based programs, and we have a monthly learning community that is open to all and provides free continuing education. We've got toolkits on building partnerships and building the business case. So I know a lot of you have learned quite a bit about addressing Medicare, and come check out our toolkit on building the business case for working with older adults in your clinic. May help you to develop some really important community partnerships. And while we don't directly train older adults and families at E4, we do provide a number of resources for you to do that. My disclosures are that I'm funded by HRSA and SAMHSA for the work that we're doing here today. So today we are going to learn together about risk factors for mental health problems, specifically in older adults, how they look just a little bit different, identify some barriers to diagnosis and treatment, and talk about some unique presentations of mental health disorders in older adults. And we'll talk a little bit about evidence-based assessments and treatments. So before we dive in, I'm going to hand over to Matt to make a couple of comments to you all, counselors and LMFTs.
We're so glad that you're here with us today, and I just want to welcome you and remind us that in the next decade, there will be more older adults than there are children in the United States. And this is the first time in American history that this has happened. There are 10,000 people turning 65 each day, and the number of older adults in the US will grow from about 56 million currently to over 94 million by 2060. 1 out of every 5 healthcare dollars in the United States, it comes from the Medicare program, and Medicare policy often sets the tone for what other payers do. So Medicare eligibility represents a golden opportunity for licensed counselors and therapists to lean into our professional strengths and apply them to support people as they age. And from the Biden administration's proposed budget to recent comments made by the Medicare program's chief transformation officer, there is clear evidence that federal decision makers want to invest in mental health care, and adding licensed counselors and therapists to Medicare is a significant reflection of that commitment. By participating in the Medicare program, the counseling and MFT professions can now have a greater role in contributing to national discussions about how to promote mental health and well-being, address the mental health workforce shortage, and strive for more equitable access to mental health care, especially for underserved populations. So licensed counselors and therapists, you were added to the Medicare program because you are well qualified to provide mental health care, and there is growing public awareness that we need your skills to support older people. Although counselors and therapists have historically had fewer opportunities to work with older adults, the door to do just that has opened widely at the most opportune time, and changes to Medicare represent a major opportunity for licensed providers and older adults who have historically had a harder time accessing mental health care, but who are interested in addressing depression, anxiety, substance use, and other challenges once given the opportunity. So we need you and your expertise as counselors and therapists to be applied to older adults, and we invite you to take what you know about empowering your clients, promoting holistic wellness, supporting couples, families, and other systems, and advocating for clients at the margins, and applying those deeply held commitments to serving older adults. I'll hand things back to you, Erin.
Thank you so much, Matt, and grateful for the opportunity to be with you here today. So want to just kick us off with a quick mention of the 4Ms framework for an age-friendly health system. The Institute for Healthcare Improvement took a look at geriatric practices that are known to improve healthcare for older adults and boiled it down into this specific framework. So what matters? Asking an older adult what matters to them in their health and healthcare, and assuring that our care plan is included, or that our care plan includes what matters. Also including advanced directives, medications, looking at how many medications an individual is on, and high-risk meds for older adults. Mentation, typically including delirium, depression, and dementia, but for mental health providers, of course, that's broader. And mobility, keeping people moving as much as possible. When I have taught about the 4Ms framework, generally I get some pushback from clinicians saying, oh gosh, mobility is totally outside of my scope and I'm not a prescriber, so I don't touch meds. Well, I'm going to invite you to come and learn a little bit more about that in one of our programs, and we'll have the link again later. Where we have created a 4Ms behavioral health program in which individuals can learn about how to use whatever theoretical orientation you currently work in to employ the 4Ms to improve the care that you provide. And it's critical to recognize that each of these 4Ms impacts each other. So for example, if I'm on a medication that's making me dizzy, that's going to impact my mobility, which might not let me do what matters to me. And as a result, I might get quite depressed or anxious. So I want to give you an opportunity to think through a case in this regard. And as we move through today's content, to think about the 4Ms and how they apply in these arenas. So Barbara, not her real name, of course, was a woman that I was working with prior to COVID, at the time a 74-year-old African-American woman with depression. And right prior to COVID, she was doing amazingly well, just about ready to graduate from therapy. And then COVID started. And she lived on the south side of Chicago, where there were race protests, and particularly following the insurrection. You may have heard on the news about the fact that there were tanks rolling through the streets of Chicago, and COVID in particular impacting her ability to leave her home and feel safe in the community and to do what mattered to her. So she was a community organizer and a teacher in the community and doing so much in the community that when COVID hit, she wasn't able to do what matters to her, right? She wasn't able to community organize. She wasn't able to teach the courses in person that she used to teach. And that was enormously difficult for her. Also, right prior to COVID, she had been going to the gym regularly with her neighbor and had been really successful in starting to feel better because, as research demonstrates to us, that mobility, that physical exercise impacts our mood. Critical factor for anyone working with older adults, really adults of all age, let's be honest, but particularly for older adults. And for Barbara, who had significant back pain, and consistent exercise really made a difference. So folks with arthritis who tend to sit in a chair, making that stiffness and pain worse. Getting moving matters. So it mattered that physical activity mattered not only for her mobility, but it mattered for her mood, right? Her mentation. And as a result, that she wasn't able to get to the gym, she started having more back pain and started taking more medication. And that medication then impacted her thinking and made her a little fuzzy-headed and made it more difficult to do everything that she was doing. And similarly, in that inability to get out of the house, do what mattered to her, and taking all this pain medication, her depression skyrocketed. So wanting to point to this intricate interplay of these 4Ms and just how critical it is, in particular for older adults who are more intensely impacted by mental health issues. And wanting to highlight that although, and we'll hear about this, older adults actually experience less mental health and substance use problems that are fewer than younger adults. However, when older adults do experience mental health and substance use issues, they have more functional impairment, poorer mobility, greater symptom burden, are in the hospital longer. And these health issues then put them at risk for loneliness, right? So the more health issues you've got, the more likely you are to stay at home and not engage in activities you might have otherwise engaged in. So although older adults have fewer or less frequent mental health issues, they have a much greater impact. And even when older adult mental health issues are identified, and part of the reason why we don't even see them is because primary care is less likely to screen for them. And so even when we do identify older adults with mental health challenges, older adults are less likely to pursue or engage in mental health or substance use treatment, in part because of ageist beliefs that you can't teach an old dog new tricks. Turns out older adults can benefit from psychotherapy in the same way that younger adults can. And less likely to get referrals even for treatment. And the fact that 1,400 of you are here today is a testament to the need for additional training for folks who are working with older adults and recognizing these unique situations. Matt's going to talk a little bit more about the likelihood that an older adult is going to be less likely to survive a suicide attempt. We'll talk a little bit more about that later. But even when provided with a referral for services, older adults are less likely to receive adequate services, in part because so many mental health clinicians of all stripes are not trained in working with older adults, and particularly if that older adult is Black or Latino. So as we start to think about some of the unique elements of mental health and substance use issues in later life, I want to be crystal clear that depression is not a normal part of aging. There are a lot of people out there who are saying, oh, you know what? She's old. Of course she's depressed. You know, she's got all these medical issues. Of course she's depressed. Absolutely not. Depression is actually less likely in later life. And we're also less likely to detect it, in particular because of the unique presentation for some older adults in later life. So we all know that in order to diagnose major depressive disorder, you need to have either depressed mood or anhedonia, that lack of joy or pleasure in activities typically enjoyed. Well, older adults are less likely to report depressed mood. So very often in primary care, when we just ask, are you feeling depressed? No, okay, and move on, we're going to miss that older adult's depression. Much more likely to have anhedonia. And sometimes that gets a little tricky to identify because an older adult will say, you know, well, I can't go out and golf like I used to. And so trying to differentiate between lack of interest or pleasure in those activities versus physical inability to do them is a challenge. So older adults are more likely to report anhedonia, more likely to report sleep difficulties, and the overlap there of sleep is incredibly challenging because that also overlaps with a lot of other things, right? And it turns out that there's a bidirectional relationship between sleep disturbance and depression that has created this new perspective that sleep problems are actually no longer an epiphenomenon of depression, but a predictive prodromal symptom, which means that if somebody's having sleep difficulties and doesn't yet meet full criteria for depression, we need to keep an eye on those folks, right? Also, older adults more likely to report fatigue, being slowed down, and ageist ideas might suggest that, oh, that's just normal aging. No, fatigue is not. Being slowed down from one's baseline is not normal aging. Hopelessness, overall body aches and pains. And while many of us who, well, as we are all aging, we might experience a few more aches and pains here and there, but an older adult might be more likely to say, everything hurts, my whole body hurts. And also more likely to report memory problems, which in a younger adult might be more accurately attributed to depression and concentration difficulties. But ageism would tell us that there are a lot of folks out there who say, oh, well, of course you're having memory problems. You're old. That's what happens. Ageism gets in the way of us detecting depression. Also want to point out that even minor or subsyndromal depression, so meeting 3 or more criteria of a major depressive episode, is critical to attend to in older adults. The rates are high, relatively speaking, in the community, around 15%. And even that low level of depressive symptom is associated with decreased function in later life. And it actually can be treated. So having that also, as we're talking about this bidirectional relationship, particularly in later life between physical health and mental health, noting chronic minor depression triples the risk of dementia. So there's still a lot of research to be done to understand that relationship between depression and dementia, but we really need to be paying attention to this and what we can do with it. And particularly in older adults, paying attention to that health behavior. Certainly, any of us who might have a depressive episode is less likely to take care of ourselves, less likely to brush our teeth, less likely to shower regularly, all of those things. But for an older adult who may be taking multiple medications, as most folks over the age of 70 are, that depression is likely to lead to a non-adherence with medication regimens, decreased physical activity, and I just talked about the critical nature of that in the example of Barbara, not eating well. And all of this can make those medical conditions much worse and be more likely to land an older adult in the hospital. And so even if we're seeing subsyndromal depression, we really need to be paying attention to it among older adults. So making sure that we're using validated screening tools. There are a lot of screening tools out there for depression, and only a small handful have actually been validated with older adults. The two that are recommended are either the Patient Health Questionnaire 9, PHQ-9, which probably lots of you are using anyway, as I know it gets used in a lot of clinics, primary care and mental health clinics. Certainly it would be my measure of choice. Or the Geriatric Depression Scale, which was created with a yes-no format with the idea that some older adults prefer yes-no to a Likert scale. My experience in using the GDS is that I get the response of, to questions like, are you basically satisfied with your life? That's a really hard yes-no question to ask, right? And so I end up getting stories and I end up getting an unclear answer. In contrast to the more symptom-focused PHQ-9. I do want to point out here that screening tools are screening tools, not diagnostic measures. I also want to point out, as Nikki just dropped in the chat, the Catch-On Toolbox has every measure that I'm talking about today, you will find in that Catch-On Toolbox. So if you're looking for any of these measures, check out that link to the Catch-On Toolbox in the chat. I want to point out here too that as I mentioned earlier, older adults can benefit from psychotherapy just as much as younger adults. Equally effective for younger, older, and the oldest of older adults. The research that's been done on psychotherapy with older adults has been on cognitive behavioral therapy, interpersonal, and problem-solving therapy, which isn't to say that other kinds of psychotherapy can't be effective with older adults. There's just been less research. And we'll talk tomorrow in the process about why these three in particular are great choices for work with older adults. We'll talk a little bit more about that tomorrow. Also want to point out that antidepressant medication can be very effective with older adults. And just like with younger adults, the combination of psychotherapy and medications can often produce the best results. So I want to highlight again, here's that 4Ms framework, the mental health benefits of physical activity. So much research done during COVID in particular, demonstrating just how important it is to get people physically moving and keep them moving for mental health. And this can be both, folks doing activities in their home. I was doing a lot of that during COVID. And again, as folks think, oh gosh, that's outside of my scope, I can't take responsibility for that. The vast majority of older adults I've ever worked with have been to physical therapy within the last year or two. As such, I might say to them, hey, can you get out that home exercise program that the physical therapist gave you? And let's get back to that. Or marching in while seated, or marching while standing behind a chair. There's some really basic stuff that anyone can recommend. And for folks who are a little more mobile, going to a group activity course for physical activity can have many fantastic effects. Not only the physical activity itself, but decreasing those social isolation elements and loneliness elements. We'll talk a little bit more about those tomorrow as well, but really wanting to encourage the engagement in physical activity. So I'm going to turn over to Matt here for a moment to talk about one of the most critical issues we need to attend to with older adults.
Thank you, Erin. So as Erin mentioned, suicide is something that we want to slow down and really make sure that we're thinking through some of the complexities around older adult suicide. To sort of lead us into a brief conversation around suicide, I want to highlight a story that Yates Conwell, a suicidologist who specializes in aging, focuses on. It's the story of Eastman Kodak, who in 1932, at the age of 77, the founder of the Eastman Kodak Company, took his life, and he left a suicide note that said, "To my friends, my work is done. Why wait?" And at the time, the local press really took to the suicide note and wrote about how it made sense that Eastman Kodak would take his life at that point in time, given that he had accomplished so much and that all of the good things about his life were somewhat in the rear view mirror. They spoke about it as if this was a rational decision for him to make at the age of 77. But what Conwell points out is that there were many complex factors underlying Eastman's death that the press really didn't have access to or didn't shine a light on. Eastman Kodak had experienced recent deaths of his mother and several friends. He was experiencing social isolation resulting from the loss of control over his company. He had developed a degenerative spinal condition that increased his pain and reduced his ability to walk and control his bladder. He may have been experiencing depression during that period of time, resulting from a series of hardships, and ultimately was wrestling with a lack of meaning and purpose that had newly emerged in his life. And so it's important for us as mental health professionals to not kind of buy into this notion that only all of the good things that happen in one's lifetime happen before older adulthood. And as Erin pointed out so nicely, ageism can really impact the way that we look at issues like this. So if we turn to the next slide, just to get us on the same page about some basic demographic data around older adult suicide. So for starters, suicide rates are particularly high among white males in the United States over the age of 85. Within this age group, there are nearly 51 deaths per 100,000, which is about three and a half times the national average in the United States. And when we look more broadly at older adults across age and race demographics, year over year, there was an 8% increase in older adult suicide in 2022 compared to the previous year. The vast majority of older adults who die by suicide had some sort of major mental health condition. And yet it's important to point out that compared with younger groups, older adults who die by suicide were less likely to admit to suicidal thoughts, less likely to have a history of psychiatric treatment, more likely to die during their first suicide attempt, more likely to use a firearm when attempting suicide, and more likely to seek help from a primary care provider prior to speaking to a mental health provider. One thing that's really important to pay attention to is the rate of suicide deaths to attempts looks pretty different in older adulthood compared to the rest of the population. So whereas broadly speaking, it's about 1 in 25 suicide attempts that results in death, within the older adult cohort, it's more like 1 out of 4. And so again, when you think about older adults being more likely to die during a first attempt, more likely to use a firearm, those are some of the factors that contribute to having fewer opportunities to find out about a suicide attempt and then get that person help, because the rate of death to attempts is so much higher in older adults. Another consideration is around risk factors. When you see any sort of changes to health status, grief experiences, a lack of purpose and meaning, as well as dementia, social isolation and loneliness, and older adults who may be experiencing other serious health conditions, these are all factors that we want to pay close attention to. Similar to the case of Eastman Kodak, these may be things that are lingering somewhat beneath the surface, and it may not be until that older adult is asked some more probing questions about how they're really doing that we begin to find out about some of those challenges and can then properly assess for suicide risk. On the next slide, what we'll see is that there are suicide assessment best practices, And yet many of these are not always put into practice. One notable statistic is that within the last month before older adult suicide, nearly half had seen a primary care provider, and another 1 in 5 had seen a mental health professional in that month leading up to their suicide. And this represents an opportunity for intervention. The fact that these individuals who died by suicide had been exposed to the healthcare system within that previous month means that we do have hope to be able to do some upstream prevention work and to really make sure that clinicians and healthcare providers know how to ask the questions about suicide that can result in more individuals finding help and finding treatment. But the statistic also suggests that there are many missed opportunities and that there may be a lack of really understanding what late life depression or other mental health conditions look like in older adulthood. Hopefully it goes without saying, but I'll reiterate that asking about suicide risk does not somehow encourage a suicide attempt. And it's quite the opposite. Asking about suicide, asking in a very direct manner, are you thinking about suicide? Do you have an intention to kill yourself? Those sorts of direct statements can really be the sort of thing that makes all the difference and allows for that more suicide-sensitive conversation to happen with the older adult that you're working with. Now, to briefly differentiate between ideation, intent, and plan, it's really important for us to distinguish between wishes for death and plans to die. This can be particularly tricky within older adult care because as people age, there may be more willingness to talk about death. There may be more, maybe more customary to be able to say, I'm not sure I really want to keep going on. And yet that can look different from a person having an intention to die. So please make a point of distinguishing between ideation, intent, and plan. You can differentiate between a wish for death and a plan to die. And similarly, you can differentiate between readiness for death versus an intent to somehow expedite the dying process through a suicide attempt. It's also important to consider access to means that might be used for a suicide attempt. And as I mentioned before, the high utilization of firearms can be something that we want to put distance between that older adult client and some of those lethal means. One study suggested that older adults have one of the highest rates of gun ownership in the United States. And within a particular period of time, about 80% of older adult suicides were completed using a firearm. So again, we really want to pay attention to those lethal methods. And as a final note, there are brief, concise, easy to use scales such as the Columbia Suicide Severity Rating Scale that are available to you for free, easy to access on the internet or through the Catch On Toolbox. This is a 6-item scale that's been designed for broad utilization across many settings. It's not just for mental health clinicians, and it really allows you to get down to the bottom of things and to ask some of those probing questions and to be able to uncover whether or not an individual may be at elevated risk for suicide. And the last thing I'll mention, when we talk about suicide risk, the other side of the coin is protective factors. We always want to be able to elicit what is it that keeps that individual alive? What is it that contributes to maybe the ambivalence that they have about both living and dying? And so when we consider protective factors, that can be anything from family members and friends, pets, faith communities, or religiosity. It can even include you as a member of their care team. So don't be afraid to have those protective factor conversations right alongside those key questions about suicide risk.
Thank you so much, Matt. And, this is such a critical issue around suicide that if you want to learn more, we actually have quite a bit more on the E4 Center website as well. In the meantime, we're going to move on to anxiety. And again, as we were talking previously about the overlap of mental health and medical conditions, anxiety is a place where that happens a lot. So older adults are also less likely to use the word anxiety, much more likely to say concern or worries. I've always been a worrier. And the content of the worry tends to change in later life, much more of a focus on loved ones, on health. For those in the LGBTQ community, a focus on sexual minority status, particularly given that the folks in that community are much more likely to experience mental health, substance use, and physical health issues, and more likely to be marginalized. And particularly during presidential election years, the state of the world, as folks are watching way too much news, it can be a source of anxiety for lots of folks. And so older adults are less likely to describe feeling anxious or depressed, and a lot more focus on physical health symptoms, and particularly in the context of anxiety. So those of us who've ever been anxious, which is probably all of us at some moment, have experienced that fight or flight experience, right? So the tightened muscles, the butterflies in the stomach, all of those things. Well, those can also overlap with other medical symptoms, right? So those same symptoms can be the result of medication side effects. I was listening to a phenomenal speaker yesterday, Dr. Andrea Schwartz, who's a geriatrician at Harvard and the Boston VA, and she was talking about how any of these kinds of symptoms that people have, and particularly delirium, when people get very confused in a very short period of time, medication side effects is the first place we need to look. This again is why I really push even non-prescribers to learn a lot about medications, and particularly medication side effects for older adults. We'll talk a lot more about that in the 4Ms training if you want to come and join us. New onset anxiety in later life might actually be a symptom of cognitive impairment. And so if somebody has been calm as a cucumber their whole lives, although I'm not sure why cucumbers are calm, I always tend to use that term, that folks who experience anxiety for the first time in later life may need a cognitive screen. And so taking a look into that situation, and particularly since COVID, those situations in which any of us experience uncertainty, folks who have a particular intolerance of uncertainty will be experiencing more anxiety at that time and really need more attention. So as we think about screening for GAD, again, that catch-on toolbox is a great place to find all of these measures. I tend to use the GAD-7, which is the partner of the PHQ-9. Same setup, freely available. It's been tested in lots of environments and with older adults. And the framing of those questions is a little bit less focused on the physical symptoms of anxiety that, again, and particularly in older adults and folks with multiple chronic conditions, can maybe not actually be about anxiety and may be about something else. So as with other mental health issues, cognitive behavioral therapy is one of the evidence-based treatments for anxiety. Acceptance and commitment therapy has also had some new research demonstrating effectiveness. One thing, though, that any clinician can do regardless of theoretical orientation is slowing down the breath. For folks who have lung issues, deep breathing will not be effective and will actually create more anxiety, but just slowing down the breath taps into that hypothalamic pituitary axis that really can slow down that anxiety in any moment. So even independent of another theoretical orientation, that can be really effective. Also for anxiety, SSRIs or SNRIs, antidepressant medications, Lexapro, Celexa, Zoloft, Effexor can be incredibly effective with older adults for anxiety. Critical that we not use benzodiazepines, one of the most dangerous medications for older adults that creates cognitive fuzziness or cognitive impairment, and actually can create long-term cognitive impairment if used long-term. And also for folks who have any sort of fall risk. So because it makes older adults unsteady on their feet. I've had older adults say, well, I've been on them for years and don't worry about it. I only take them at night. Oh, great. So when you wake up in the middle of the night and you're fuzzy headed anyway, and you're even more cognitively impaired and more likely to trip over something in the dark. So benzodiazepines, dangerous for older adults. Get my slides to move forward here. There we go. Wanting to talk a little bit about substance use. Ageism would tell us older adults don't use substances. They're old. Why would they do that? And yet, the growing number of older adults who are using substances is really important for us to attend to. Don't assume anything about older adult substance use. Critical to attend to, as I had an older adult who was referred to me for grief, and I neglected to screen him for substance use. And it wasn't until about 5 sessions in that he let me know that part of his grief was so profound because his 5-year-old grandson died while under his care, and he was high on crack cocaine. And this is a 75-year-old guy who started smoking crack in retirement because he was bored. So we really have to pay attention to this. And also, even folks who have been having a martini after work for years on end, that same martini has a very different effect because kidney and liver do not function in the same way. They decline in function in later life, and even how the stomach absorbs various chemicals. Those physiological changes make the same amount much more potent and much more dangerous later in life. And as if that's not enough, alcohol and any other drugs can interact with medications. And we just don't know enough yet about cannabis in particular, about how that's going to impact. And I know there are a lot of older adults out there using cannabis in particular for pain or for sleep. But it could be very dangerous in terms of that interaction with medication, and in particular for cognitive impairment. That substances of any kind, and including cannabis, can exacerbate cognitive impairment and get in the way of improving mental health, and certainly are a fall risk. So anyone who's ever seen anyone who's drunk or high, they're a fall risk at any age. And then when you add on the challenges of mobility in later life, that's even worse. So the highest risk for substance use in later life, white men with low socioeconomic status. But I do want to highlight that opioid deaths are highest among Black older men. So wanting to pay attention to that. And, as Matthew was talking about earlier, really paying attention to those life circumstances. Folks of any age, and particularly older adults, are much more likely to use substances while going through life transitions. And in later life, that may be retirement, death of a spouse, again, identifying as part of the LGBT community, being socially isolated, experiencing health issues. These are all common elements in later life. And of course, those with a history of substance use or mental health issues. Alcohol is most common, and some folks may misuse their medications intentionally, or some might just mismanage them. I'm going to move through to mention a couple of screening tools here. Again, all of these are in the Catch On toolbox, and strongly encourage you to use a tool validated with older adults, because some of the tools that have not been validated with older adults are not going to effectively detect what you're looking for. So interventions can be incredibly effective. SBIRT, you may have heard of, screening, brief intervention, referral to treatment. A lot of folks just aren't aware that that same martini or 2 beers have a much greater effect later in life. And so just need to be informed that it's not safe to be drinking that much. And so a lot of folks will, oh gosh, I didn't know. I just kind of what I've always done. Cognitive behavioral therapy also effective, motivational enhancement therapy. Not too many centers are designed to accommodate older adults, but a lot of centers do actually treat older adults. There is also a version of Alcoholics Anonymous for older adults who tend to feel more connected with folks their own age, called Seniors in Sobriety, can also be very helpful. So wanting to mention that grief is very common later in life, as loss is common later in life. But I want to point out a distinction between normal grief and prolonged grief disorder. Full discussion of this is beyond our conversation for today, but wanting to point out that folks who may experience sadness or being stunned, being shocked, that is all very normal grief. But returning to oneself and still feeling like a whole person is also normal. Prolonged grief disorder, in contrast, makes it very difficult for someone to even think about anything other than the deceased, and feeling like you're completely lost half of yourself. Now, granted, older couples are much more likely to describe their grief in that way if they lose a spouse, but still not experiencing the other symptoms around disbelief around the death, numbness, meaningless, intense loneliness for more than 6 months. That those symptoms may be present in individuals immediately after a loss, but if after 6 months, psychotherapy is required for intervention. Medications don't work, by the way. The companies have tried, and those trials are not effective. What does work is cognitive behavioral therapy, interpersonal therapy, complicated grief therapy, and for some, support groups can be very helpful. So I mentioned that I was going to plow through all of this content very quickly and point you to a number of resources that may be very helpful. Greg Hinrichsen wrote a book about assessment and treatment of older adults that is not specific to any theoretical orientation. It just really walks through the competencies in working with older adults. It's a fantastic book. For those who work in a cognitive behavioral therapy approach, Ann Steffen, Larry Thompson, and Dolores Gallagher Thompson wrote this fantastic clinician guide, and there's a patient guide that goes with it. Strongly recommend this as one that might be helpful for you. And here I'm going to pause for a minute and hand over to Matt to make a few additional comments.
Yeah, I just want to note that in addition to all of this wonderful content, it's really important for you as clinicians to think about how to make your services as accessible as possible for older people. And this is, really something that we could get into in a later conversation. But, I encourage you to think about what accessibility looks like. That might mean proactively linking up with primary care providers, aging services professionals, others who may have a long history of supporting older adults. So I encourage you to not just wait for older adults to find you, but to think about how to proactively position your services so that they can be easily found and accessed. And I'll just, one very brief example of this. I recently visited a dynamic senior center in Wilmington, North Carolina, where they've hired 2 licensed counselors, brought them on site to provide counseling services right there at the senior center. And these older adult clients who are facing a litany of issues have really found that it's most helpful because this is a place that they trust. This is a place that they're accustomed to going to. It's really been a resounding success. And these are ways that we can integrate mental health services right there into places that older adults are likely to find themselves. So I just encourage you, as you're really considering how to reposition your practices to serve older people, to think about accessibility and what that means for how to make your services as available as possible to older populations.
And if you want to learn more about how to do that, the toolkit on the E4 Center website about building a business case will help you to do that. I want to point to just a couple more resources very quickly here. Greg Hinrichsen and I had a special issue in Clinical Psychology, Science, and Practice that walked through the 5 competencies for working with older adults, foundational knowledge competencies in geropsychology. These are fantastically written pages, and we've got the link in the chat to that special issue. I also want to point out again that 4M's behavioral health training that I mentioned that starts in April. We have a 3-hour training to kick it off, and then 1 hour once a month for 5 months to really solidify those skills and being able to implement the 4Ms. That link is in the chat. It's the same link I mentioned earlier. Strongly encourage you to do that. Free continuing education is available for this event. And for those of you who really want to learn more, we have a 16-hour online foundational competencies in older adult mental health program. And for those of you attending today, I'm offering a 25% off discount. Use that code that's in the chat there, the MMHC 2024. This is a fantastic program that is peer-reviewed, evidence-based evidence information itself, that has been really positively reviewed by folks who have taken it. So strongly recommend, and for those of you who live in states with requirements for your licensure around dementia and ethics, we've got both of those right here. And it's really cheap to start out with. It's only $175 for 16 hours, and you get 25% off for showing up today. So if you're interested in learning a little bit more, come check out the E4 Center, come check out Catch On, our geriatric workforce enhancement program. We've got a wide variety of different elements available for you, and lots of free CE in working with older adults. So with that, I'm going to welcome Jolie into the conversation and see what kinds of questions we might be able to answer.
Thank you so much. Thank you, Dr. Emery Tabucio and Dr. Fullen, for sharing your time and knowledge with us today. We've learned a great deal about effectively working with older adults, provided some vital information, and we appreciate your partnership very much. The options are limitless, as you have pointed out, for getting education and working with this population. We now want to move to the question and answer portion of our program. We have a few minutes left for that, and we have a few questions that have come in. If you and Dr. Fullen are willing to answer a few, that would be wonderful. So let me see here. One question that's come in is working with older adults a specific certification that we can get, or is it more self-study?
So it's a great question. And as I just mentioned, the foundational competencies in older adult mental health certificate program, folks can complete that certificate and, have something to hang on your wall if you'd like to. That said, there isn't an official certification in ways that, for example, a certified chemical dependency counselor may be certified. So there isn't anything official necessarily. But would strongly encourage you to check out the foundational competencies articles and online training program. And there's lots of opportunity for self-study. So if you're looking for anything else in particular, please don't hesitate to reach out to me. More than happy to help you find a path through that training.
Wonderful. Thank you so much. Another question that came in is, when someone goes through life believing symptoms of depression are things like low mood, crying spells, how can we convince them as they get older that they are possibly experiencing depression when their symptoms are more along the lines that everything hurts, they're not eating properly, not following doctor's orders to take care of themselves?
It's a great question. And, one thing I have actually done with patients is open up the DSM and walk through the symptoms and say, this is what depression is. And, sometimes with mental health disorders, it seems like all these symptoms that just kind of hang together and they're this syndrome. And it turns out that we know that we can treat this syndrome. This is actually good news in contrast to a lot of other things that we don't necessarily have effective treatments for. So, I used to do evaluations in a dementia clinic, and I remember calling up the wife of a patient at one point and say, "Hey, I've got great news. Your husband's depressed." She's like, "I'm sorry, this is great news." "Yes, it's great news. I can't treat dementia, but I can treat depression. We can do something about this." And so helping people to understand that all over pain is actually a reflection of hormonal changes in their body that come with depression can go a long way. So yeah, I tend to kind of come back around to the DSM and help people understand that this is what this looks like. Matt, I don't know if you have other perspectives on that.
Yeah, and I know some of this we'll get into tomorrow as well. So I invite everyone to join us again. But there can be subsets of older adults that have lower mental health literacy, and so it's important to be able to take the time to really provide education about what depression is or isn't, what treatments are available for that. And to Erin's point, that this can be something that is amenable to treatment, and so that's really can be a positive. But keep that in mind, that with older adult populations, there may be some underlying stigma around mental health care that has to get worked through so they can really open themselves up to your treatment.
Very good. Thank you. I wanted to ask you, Dr. Fuller, we've had a couple of questions come in about suicide. And one question that came in was in regards to some states that have passed legislation in support of physician-assisted suicide. You didn't necessarily speak to that, but one person wanted to know if you could make some comments around that.
Yeah, I mean, older adult suicide because of the complexities of individuals who may be nearing later phases of life, who may be nearing the end of life, who may be dealing with various medical challenges along the way. It really is important that we take the time to sort of tease that out, and to be able to make sure that with the person who's seated in front of me, are there issues related to suicidal ideation or even intent that are primarily an outflowing of the pain they're experiencing, the suffering that they might be going through, and could be secondary to a mood disorder or other mental disorder. And if the answer is yes, then we want to make sure that those are aspects of their suicidal ideation that can be treated, and there can be good life on the other side of that, if the individual has an opportunity to be able to work through some of those pieces in mental health treatment. So it's important not to race to any conclusions about what that individual may or may not really want. There can be a high degree of ambivalence about living and dying, that certain older people are wrestling with. And so, counselors and therapists are really good at having those sorts of conversations about values, about helping people sort through what it is they really want. And it may be that individual really wants to, wait for the turnaround to happen, but isn't quite sure how to get there, and maybe feeling hopeless about whether that's even possible. Certainly within states where physician-assisted suicide is legal, there is another layer of conversations that need to be had. But I think it's important to not primarily assume that the older adult suicide conversation is just a physician-assisted suicide conversation. The reality is that there's a lot of suicide prevention resources that can help older people experience health and well-being if given the opportunity.
Very good. So it's a very layered question, and the answer to that is it's complicated. So thank you for addressing that. I think we have time for one more question. I actually think this one is really good. Someone has written in asking, what are the best ways to handle working with older adults who struggle with feeling that a therapist younger than them can understand and help them?
That is a question that comes up in every graduate program addressing this, as particularly if somebody looks very young. And I think, much like we might address any sort of uniqueness about a client, that, their skin color may be different, their religion might be different, their, pick your layer of intersectionality may be different. And I think it's really important to have an explicit conversation about that with the individual and say, you know what, you and I do have very different life experiences. And so I will trust you to teach me about your life experiences. And my training has taught me how to work with you to potentially reframe those ideas, or think about them a little differently, or perhaps act within them a little differently. I have conversations almost every month with actually Barbara, the African-American woman who I've been working with now for some time. She's like, you just don't understand what it's like to be Black. And I said, no, I don't, and I never will. But I need you to explain to me what your experience is like, and maybe we can think it through together. And I think the same thing goes with age. And so every layer of intersectionality is an important one to attend to. And I know, Matt, working in a graduate program, are there other things that you would add to that from your students?
No, I would echo that. Yeah, our students tend to think about other identity or diversity constructs, and then become over time increasingly comfortable working with people who don't resemble them. And yet with age, oftentimes that is one piece that is not as well explored. So I think just exposure, repetition, being able to help younger either students or professionals really think about, how can I take my expertise? How can I bring that into these therapeutic conversations? And how can I take a stance as a learner from my client, so that they can really educate me about what it is like to experience this age of the lifespan, and then to not shy away from the things that you do really well to be able to contribute to that healing.
Very good. Thank you both for that answer. Unfortunately, we're out of time for questions. I do wish we had more time, but we do not have any more time for today. The Medicare Mental Health Workforce Coalition and NBCC would like to thank our speakers, Dr. Emery Tabricio and Dr. Fullen, for sharing all their knowledge. We also want to thank the participants for attending today's webinar, and we look forward to seeing you again tomorrow as a follow-up to today's webinar if you're able to join us. In addition, we have included a few Medicare resources on the next few slides for your convenience. The link to the session evaluation is posted in the chat, and we will also email that to you following the meeting if you don't have a chance to get it in the chat. To receive continuing education credit, you must complete the evaluation, including the attendance attestation, by April 4 at 5 p.m. Eastern Time. As a reminder, the continuing education survey link will allow you to complete the evaluation for one or both of the webinar sessions. The certificates will be emailed by April 11th, and we will only be providing credit for the live attendance of this webinar. We hope you found this session informative, and we look forward to seeing you again tomorrow. In addition, we will continue our Medicare webinar series on April 18th, and the focus of that webinar will be navigating the Medicare Advantage plans. And we will let you know when the registration begins for that webinar as well. Thank you and have a wonderful rest of your day.